Hello again. My name is Dr. Mark Casanova. I am speaking on behalf of the Texas Medical Association, the Texas Hospital Association, and am a practicing internist, palliative care physician, clinical ethicist, and medical educator, and speaking with the utmost respect for Representative Parker, but against Bill 2609. I've provided you written testimony, so what I really want to do is concentrate on a clinical scenario of which I've been involved most recently as a clinical ethics consultant, and as the chief of our clinical ethics department. I've personally been involved in 046 journeys. By the way, one of which was a scenario that we oftentimes forget about. It was a scenario where the family desired withdrawal of treatment for their young adult son who was a victim of a motor vehicle collision, and the physicians felt quite strongly that more treatment needed to be provided. So we actually utilized the process to begin the mechanism to continue to provide support. The other four were the more classic scenario. I've provided hundreds of ethics consults in my 18 years of doing clinical ethics consultation, and again, an overwhelming minority have been 166046. I may be asked about it in about 1 in 20 times, or over the last 4 years, 1 in 30 times. Have any of these progressed? And my usual recommendation to my treatment colleagues is, if it's a matter of a trach or peg, we place that trach or peg and get the individual to the next destination. I practice at Baylor University Medical Center, which is a quaternary care center. There's very few centers higher than the level of care that we provide. In the case I'm going to present to you occurred this last summer. It was a case with an individual who was ravaged by COVID. He entered our hospital as a transfer from another hospital, which is very common for our institution as being a higher level of care. We placed him on ECMO, which is in essence a heart-lung machine. It's the highest level of life support that exists. There is nothing greater than that. Quickly upon his arrival, his kidneys failed and we realized he had strokes. It was not till day 24 that clinical ethics was consulted. After consultation and involvement with supportive and palliative care, even before my very first meeting with the family, requests for transfers had been requested by the wife and were in place of exploration. It was another month before we met with the Medical Appropriateness Review Committee. I want to read just a couple of lines from my contemporaneous notes. The end result is one of the most profound cases of anasarca, that's excessive fluid in the body, that I have witnessed in 20 years. His body is weeping and necessitates the nursing staff to keep him surrounded in absorbent shucks. His skin glistens with an incredible degree of tightness. His edematous conjunctiva, the lining around our eyeballs, are protruding through his closed lids. Many of the nursing staff have expressed to me the moral, spiritual, psychological difficulty they are having in providing hands-on care to him in this state, knowing that we are not able to save him, and the fact that his current appearance is, quote, our doing. So when we talk about moral injury, and I did a study on moral injury with a nursing colleague at my institution in 2013, some of the greatest moral injury and moral dilemmas that that healthcare providers face that lead to burnout relate to these types of scenarios. One last couple of lines. As physicians and as ethics consultants, we do not take the initiation of 166046 process lightly. In fact, and to be candid, I've attempted to forestall the initiation of this process as long as I felt was feasible. I did this for the singular purpose of hoping that with a combination of support, tincture of time, prayer, and exploration, we would be able to reach resolution. We have certainly also seen cases where God makes that decision for us. I'll abbreviate it there and say through 2 deliberative meetings, we chose not to proceed with the formal initiation of the 10-day clock. Dovetailing off of what has already been presented by my friend, Ms. Allman, there are improvements to be made, many improvements to be made. Data collection, record keeping, looking at the time frames and ensuring that they really truly are appropriate in modern day medicine. Those words I wrote about Mr. Smith's edema proved woefully true. Hours later, due to the sheer swelling of his body, his scrotum ruptured, sending bodily fluid across to the nurse who was standing there. They then had to use the same tubing that we use for ECMO to insert into the defect, purse string it, and provide a conduit for this fluid to be drained off of his body. He ultimately was coded, underwent CPR for 30 minutes at the closure of his life, despite the best of our efforts. In totality, his hospitalization lasted 90 days on ECMO. In that time frame, mind you, this was a summer, the average length of time that any one of our ECMO pumps remained free was the time it took to explant or disconnect the pump and place it on a new patient under our roof, or bring in another patient who was ravaged by COVID by an outside hospital. I can say with the utmost of confidence that many lives were not saved that possibly could have been, given what we learned about the treatment and utilization of ECMO in that time frame. I'm open for questions.
Dr. Casanova, I've helped transfer
Yes.
and find facilities for some of these patients. And again, as I mentioned to Ms. Allman, there are some facilities that will not do the needed procedures in order to facilitate that transfer, be it trach, be it a G-tube, and that's a problem.
Yeah. No, and in my Mark Casanova opinion, I agree. And I think that's why if we can come together with stakeholders and individuals who have personal experience and have been through this process and maybe help guide other entities and other institutions, that we really need to take a step back here. And if it is a trach or a peg, that need not be looked at necessarily as an escalation or intensification of treatment or management or support of our patient, but a part of the package of the support. And if that is what allows transfer, that should be done.
Yeah, there was another man that I was involved in that had an anoxic brain injury. While he was responsive and would smile when his children walked into the room, that man was subjected to a 10-day countdown. And all he needed was to be fed.
Well, and
he needed rehab.
Right. And with the changes that were made, and please forgive me because I can't quite remember where along in the process, you're not able to withdraw artificial nutrition, hydration in those processes, and which is one of the reasons, again, for umpteen years, our institution and our approach in our healthcare system is to not utilize this in situations where our loved one sadly is vegetative, just a severe anoxic brain injury. Other organ systems are functioning, and many of these individuals, as you say, they will be able to eventually be liberated from the breathing machine, and what they need is ongoing artificial nutrition and hydration.
This man didn't even require ventilation.
Right.
All he needed was to be fed, and he needed rehab. But they had an ethics committee, and the ethics committee decided that they were going to discontinue his nutrition.
Yeah. And I think that, again, that's where the reporting mechanism, I think, would be key. And in bringing, working with the Texas Hospital Association and Texas Medical Association, all those other stakeholders together to ensure that individuals are following the spirit and the essence of the law, along with modifications and evolution and growth of the law that should occur.
Yeah, it may be working well in some institutions, but in others it's not.
And we understand that.
We need to fix it.
And we hear a lot of stories, and every single one of them, regardless of where they fall, are stories of sadness, sorrow, and ultimately loss, and loss that is universal, because we are, in fact, dealing with end-of-life situations.
I've even heard some families, after having a very negative experience in a particular facility, tell their family and loved ones, please don't ever let me go there again. If something happens to me, get me out of there because they've had a bad experience. And that's unfortunate. Some facilities do a better job, more care and kindness in dealing with patients and families going through a really, really hard time. Members, any other questions? Representative Alverson.
Thank you, Madam Chair. Mark, I appreciate you being here. These are hard. I mean, it's late. Obviously, we got another bill to go, but I'm glad we're taking the time to talk about this, because I think, these decisions have troubled me since I was a anesthesia resident in the neurotrauma unit. I've been in the room at 3 a.m. with a patient and wondered to myself, is he still with us? Is he not? Because the machines seemed to indicate that he was still with us, right? I can't tell. I don't know if you can tell. I have no idea when a person is with us, when they're not with us, when a soul has departed the body, when it hasn't. I've heard some of my colleagues say that they think they can. I question that. I'm not really sure if that's true. But you brought up a topic. I mean, I have really a couple questions for you. So first of all, I guess my first question is, I've always wondered, why 10 days? What's the magic there? Because, I mean, you know, normally we would put somebody on a ventilator for 2 weeks before we would recommend a tracheostomy and a PEG tube. And listen, I'm a busy anesthesiologist in private practice. And with COVID, we did that all the darn time. And that is not like the end of the road in care by any means for a large number of patients who are critically injured or critically ill. And it's always bothered me that we just sort of have this number. And I was wondering, do you have any knowledge of why that's the magic number? I mean, why not 20 days? Why not 5 days? I mean,
So a couple answers to that. Number one, I wasn't involved in 98, 99. I was wrapping up med school at that time. But it is important to acknowledge this is not 10 days of treatment. This is not 10 days of hospitalization. This is 10 days after, typically, in my personal experience, on almost all my ethics consults, the patient has been in weeks, if not months. And now with modern era of supportive and palliative care, to really embrace these families. Our team was involved with Mrs. Smith, and we were at opposing opinions, but we had a great relationship. We prayed with her. We brought in her faith leader. We allowed her to bring in culturally appropriate symbols of faith into his room, into his ICU room. So the point about 10 days is, let's not get confused that this is 10 days of treatment in the hospital.
I'm not saying it's 10 days of treatment.
Right. This is
you know,
10 days after.
Why is 10 days, so the family's informed of the
I
decision?
can tell you why,
And,
if
yeah.
you really want to know.
Yeah, I'd love to know why.
Well, when you negotiate a bill, you negotiate hard.
Okay.
And you start off with a low number of days thinking that it's going to not go that way. That's what happened.
Yeah. I mean, I think some of our current exploration in the coalition is, in fact, a greater number of days on the front. Greater number of days on the back end. And again, you know, as I said already, I turned down 1 in 20 to 1 in 30 inquiries of, Mark, could we use this process? And my answer is reflexively no, and no for these reasons. And place the trach, call anesthesiology and place the trach. So the 10 day is really was a way, as Representative Coleman put, to sort of find the middle ground and realistically, in the spirit of the notion of what I think was in the mind of many individuals who crafted this and who were together at that table many moons ago, 22 years ago, was, if you're in a quaternary care center, for example, tertiary care center, how long does it really take realistically? And can you find that other institution? That's really the vision of this, what should be a narrow
How long
group
does
of
it
individuals.
normally take to find an institution?
So if you're asking step down, equal, or higher. Step down, my wife is a social worker. She actually works with our team. She can get you transferred in 24 to 72 hours max.
I mean, if it was step down.
Everything copacetic. In other words, hey, we've got that trach, we've got that PEG, we need to go to an LTAC. She can get you there in 24 to 72 hours. If it's a lateral transfer, it depends on the level of care of the institution. If it's lateral at a tertiary, a quaternary care center, you need another ECMO center.
And I think
You may not have that. And then if it's an increased level of care, that should, in theory, also be that 24 to 72-hour window, right? Let's bring that person in, as we do, and let's give them that time-limited trial. Let's try this to see if we can save them. If it's God's will and we get lucky with this one, right?
Yeah.
So yes, let's bring them in. So going down a tier, going up a tier should, in theory, in normal circumstances, let me emphasize that, be 24 to 72 hours. We get nervous as heck if we have a request for a patient to come in. My thoracic surgery friend who worked on Mr. Smith, for example, was having to tell people, no, no, no. We had, on average, 5 individuals waiting for an ECMO that we could not bring in because we didn't have the ECMO. So a part of this is real world scenario and then these other situations. So I think a 72-hour on average transfer. I think what happens in many of these situations is the clinical assessment is made and the clinical facts are shared, and it is difficult to find either the same level of intensity of treatment and or another receiving institution and physician who feels that, yes, it would be appropriate to bring this, and we can offer something different than is already being offered.
Last question, and you kind of hinted at this, but this is one of those things we kind of don't want to go there, but I feel like we have to go there because it's
Sure.
part of the conversation.
Right.
And that is that you brought up the fact that this gentleman that you were talking about, that it sounds like he had anasarca, basically.
Because he had renal failure, he was on CVVHD, he was on multiple breast results,
Sounds like
doctor lingo,
you
but
mentioned that he was on
multi-system
ECMO
organ
and all this
failure.
stuff, which, so there's a scarcity of resources thing going on here. And, I hate to open this can of worms, but I mean, this part of this conversation is, let's talk a little bit about that if you feel comfortable. But I mean, how many ECMO machines do you have? And if they're all used and somebody needs to be on ECMO, what happens? And so as your perspective from a medical ethicist, how do you walk us through how you wrestle with issues of medical scarcity and triaging and understanding? So when somebody's already in the bed,
right.
can you throw them out of the bed to put somebody else in the bed that may be more salvageable? I mean, what are the ethics of that? Because I think that's part of it, right? There's definitely a scarcity component to this because we don't have unlimited medical resources.
Right. So I will say this because I ran into my colleague in the hall Tuesday, whatever day today is. I think it was yesterday. And I asked him, how are we doing on ECMOs? He said, today is the first day that we have a free ECMO, that we call them a pump, that we have a free pump. The first day since, I think it was April. So there is a scarcity of resources, and I think the way that the best of the hardest ways to address it is clinical discernment of who is likely to benefit, with the ultimate goal of saving as many lives as possible, understanding that not all is possible to medicine, and we're not going to be able to save everybody. So I mentioned that the gentleman arrived in June. We had already learned a lot by then, but we've learned a ton more in that interval. We likely would not have accepted him a month later because of the sequential organ failure he was demonstrating. His kidneys were, in essence, failing en route. So we use a lab value called creatinine. That tells us how our kidneys are doing. It bumped at the home institution. By the time he arrived us, it had doubled. The next day, it was tripled. It was clear he's in overt renal failure. 2 weeks into his stay, he demonstrated neurologic changes. You mentioned that sometimes it's hard to know. When we think about it, on ECMO, it's almost, I've jokingly referred to it as sometimes a vampire test. You can have circulation and oxygenation, a perfectly normal oxygen level, and not be moving air. Not even be in a breathing machine, by the way. So folks who are on ECMO but on a breathing machine. So if you did the good old-fashioned, Bram Stoker, hold a mirror under their nose, there's no breath. So we've learned, and then we discovered he had multi-embolic infarcts, so multiple strokes in his head. So all that being said, our mortality experience with ECMO did a switch. It went from 75% mortality, which is about the national average for COVID. And as nationally and internationally we learned, these are the cases we use it in to optimize survival, we're down to 25% for those who get on ECMO, which again are the sickest of the sickest of the sickest of the sickest.
So is medical scarcity in and of itself its own ethical dilemma?
It is absolutely its own ethical dilemma. It's its own area for conversation and exploration. the notion of medical scarcity was expressed by these bedside nurses and these bedside ECMO techs and the staff who were struggling not just with the reality of what was unfolding. We're not going to be able to change it. And the knowledge that I'm not able to save another life. And that was explored in the dialogue. And we chose not to factor that into the decision-making because to fundamentally answer your question, no, we can't make that decision.
Yeah, you have a tough job, my friend. I'm glad that you do what you do because people like me sometimes, need someone to talk to, so.
Right.
I mean, these are hard. I'm not
And
here to
I
say
shared
that
it in
any
the
of this
Senate,
is
the
easy,
majority of
so.
what a clinical ethics consultant does is counseling. So, we said our goodbyes to Mrs. Smith and prayed for her in her sorrow, an immense sorrow. She loved her husband a gargantuan amount. My follow-up counseling and bereavement support was, however, for the staff that unfolded over a month, just session after session, working with our chaplains, supporting our nurses who struggled and who still struggle to this day.
Representative Allison?
Thank you, Jim. Dr. Casanova, just a couple of questions about the process to see what options might be available or refinements perhaps. It all starts with the attending physician or care team, correct?
Yes.
They make a determination that they've done all they can medically, and then they try to work out an agreement or understanding with the family. If that fails, it goes to the ethics committee?
It goes to the ethics consultant. The ethics consultant comes in, reviews the records, meets the family, counsels, and also makes the determination at that point, does the ethics consultant agree with the treatment team that this is in fact medically inappropriate as defined by being therapeutically non-beneficial. Many times, as I already said, we stop there.
And the ethics consultant is a physician?
In many institutions, but not always. They could be clinical ethicist. There's a variety of roles that an ethics consultant could be. I personally am a physician, but you could have different roles.
All right, and then from there it goes to the ethics committee?
Then it's taken to the ethics committee with a meeting that we refer in our institution as a meeting of the MARC, M-A-R-C, Medical Appropriateness Review Committee. The family is given written notification of the process and an invitation to attend the MARC meeting along with the treatment team. That meeting can take place no sooner than 2 business days. In all my experiences of the 4, because when we started the process with the young man, the family said, no, we've come around, we want to keep supporting it because he was showing an improvement. Then the Medical Appropriateness Review Committee hears the perspective of the family, here's the perspective of the treatment team, and then they deliberate amongst themselves, and then we'll then share with the family, usually the next day, because these invariably take place in the evening, in writing, the decision of the Medical Appropriateness Review Committee, the Ethics Committee, as to pursuit of the 10-day window. In the case of Mr. Smith, we met twice and twice decided not to pursue. And as I've written in my notes, based on really fundamentally empathy and trying to balance the hurt and the trauma that the wife was experiencing in her anticipatory grief and the hurt and the trauma that the treatment team were experiencing. So, it's oftentimes referred to as a 10-day process, but in reality, it's usually once I, as an ethics consultant, have that first visit, it's not uncommon for it to be a 15 to 20-day process. And again, the coalition is looking at extending the front end time, extending the back end time, trying to reach agreement.
But that's from the ethics consultant. But what about then, where does the ethics committee fit in next?
After that, so ethics consultant makes his or her assessment, decides we are going to proceed, informs the ethics committee, and then informs in writing with clear explanation of the process to the family, the invitation to the Ethics Committee meeting, the MARC meeting, which again can take place no sooner than 42 business days.
And what's the composition or the customary composition of the Ethics
In
Committee?
our institution, we have an ethics committee that has about 30 folks on our roster, physicians, nurses, social workers, dietitians, chaplains, outside community representatives. Let me rack my brain because I know I'm forgetting folks.
Is that pretty standard, or does it vary from facility?
It can vary, which again, as Ms. Allman had alluded to, that again, one of the many things to look at is what is the constitution of an ethics committee, and let's ensure that it is in fact multidisciplinary and has adequate representation from multiple disciplines, because we may see something as a physician, then we hear a perspective from our chaplain or a social worker or a nurse, and it really makes you change your perspective, and it gives you that additional insight that's important and necessary.
And will the committee obviously considers medical care matters, but will the committee also consider financial matters?
No, we don't tend to.
So you
right.
don't consider the cost
No,
of what this
no.
care is providing?
No.
Strictly keep it with medical
Right,
care?
right.
Okay. And then where in there does the 10 days or whatever period start to run? After the medical, after the ethics committee?
After the medical appropriateness review committee, and only if the ethics committee says we agree with the ethics consultant who is agreeing with the treatment team that ongoing supportive measures.
Okay. And then if the decision or recommendation is that we can't do anything else, we need to look for a transfer, how does that take place? What's involved there?
So in our institution, and again, in our cases, in a lot of cases, that exploration of transfer has already started. Remember, these situations arise because there's a disagreement. So we oftentimes find that even as I'm entering just as an initial ethics consultant, requests for transfer are already in the works or have been requested. So the process, the nomenclature we use is sending out clinicals. So you send out the clinical information to either the family may say, I want you to send the clinicals to this particular institution. Great, we'll send the clinicals to that particular institution. Do you have a physician there in mind? No, we don't, but can you just use the transfer center? There's transfer centers that do all this work. Sometimes the family will say, I had this particular physician in mind. Would you send the information to them? Yes, we will. So we send them the information.
Because the proposed receiving facility has to be able to review the medical records.
Right, exactly. So for
not
example, the
just
Mr. Smith, if the receiving institution, if we send it to someplace that doesn't do ECMO, well, that's a non-starter.
Okay, doesn't that
So-
take some time?
Right.
Fair and reasonable, doesn't that take some time to prepare those records and for them to have
Right.
an opportunity to
Right.
review them?
Right.
Okay,
Which again, is that 24 to 72 hour window. And a lot of it depends on, are we going up, lateral, or down?
okay, thank you.
Yeah.
Madam Chair? Oh, I'm sorry.
Representative
I
Collier?
was going to say, the objective is an effective transfer,
Right.
not just the transfer. And that, because the original bill didn't have two doctors have to agree. It only had one doctor, and it was vetoed. And then we came back and rewrote the bill to where the doctors had to have two doctors agree that this should move forward to the ethics committee and try to create an effective transfer. And I say that very clearly. Also, if you go on the computer, go to Diane DeLisi's bills in 2007. I don't know the number, but it was 2007, carried by Chair Diane DeLisi, and that's the bill where we made the changes that actually it got on the last calendar. And a lot of the changes that we're discussing were in that particular bill as it passed out of committee. So just so you know.
Representative Collier?
Thank you, Madam Chair. I really struggle with this bill because I heard Ms. Dye testify, and my heart goes out to her. And then when I was a child, I remember one of my friends, was 16, had an asthma attack and was in a coma, and they talked about taking her off of life support. I don't know how, but 2 years later, she became conscious, I suppose, but she didn't have the same quality of life, and she had to go to a home. And so it really tears me apart to think about this. But Representative Allison talked about the cost, and there's no cost for life. I mean, there's no comparison, but I do want to know if this has been thought out, like who pays for and I know that's not part of the ethical decision, but is the hospital or the insurance company, if we're going to do this, is there any provision in here that requires them to cover these costs so that, I mean, a hospital could go under, what is that thing you said? It's an MO?
Oh, ECMO.
ECMO.
Right.
And I assume it's a ventilator.
Yeah, an ECMO filter, just the filter for the machine is a $10,000 filter. The average length of care, the average cost of care in a tertiary care ICU hovers around $10,000 a day. And actually, that's dated data. It's probably higher than that. The filter of the machine itself is $10,000. Now, to the points that are sometimes made that, well, this is about money, that Mr. Smith was insured. So the institution received reimbursement from his insurance. So
Well,
which side of the argument is the reimbursement on? Is it, well, are we doing this to save money because the patient's uninsured? Well, in this case, we could have said, well, we're receiving money, so we're just going to keep doing that. But we don't do that because money isn't the point, whether the individual is funded or not funded. It's, can we afford, can we offer, can we achieve clinical improvement? And at a minimum, can we even sustain? And even my own personal thoughts on this and the evolution and the individual you mentioned who had a brain injury and then lived in a facility. I think many of us over the last 22 years, our thoughts have evolved. Our perspectives have changed on who would we apply this to and who would we not, which is why you've seen, I think, the usage that our data shows is that the utilization of it has gone down dramatically. And in our shop, as I said, I've had 5 that I was personally involved in, and I think 2 more in, well, a long time, since 2000.
Okay, well, I was just trying to get at if we're going to do this, because if a hospital must continue treatment, and I'm not, because it sounds like they have to do life, not only life-saving, but anything that would try to improve their life. How long are we talking? I mean, are we talking 3 years, and what type of efforts are expected of the family to try to find a transfer facility?
Well, so I'll share another clinical vignette. We had and this speaks to who this would be used on and who it would not be used on. We had a gentleman who was very well known in our institution because he was a resident for 1 year and 9 months in our hospital. On dialysis, had an anoxic brain injury from a cardiac arrest, actually developed cancer in our hospital during his stay, and we subsequently treated him. It was a type of cancer called lymphoma. But he had a valid advance directive that said, that indicated, even if I'm terminally irreversible, please do all that is possible. He had early in his hospitalization well-documented conversations with the treatment team that said, in essence, paraphrasing, I want everything done. And he had a loving, again, wife who wanted everything supported for her husband. We could not find a transfer.
Okay, so doctor, I'm so sorry. I know we have a lot of going on, and I know you have plenty of stories that would help us. But in this bill, do you see anything in there that describes the effort that the family has to put forth to have that transfer? I'm just trying to make sure that we can pin things down. Right. And I want to know if you see that in here. Like, do they have to call once, twice? And then what happens if they... So
I can give you what we do. I'd have to study the bill. I'm sorry about that. In terms of what's the outline, what's the process that's spelled out. In our process, families have said, I would like transfer to X facility. But the reality is it's our social workers, it's our care management team. It's us that are putting out those clinicals. The family gets a disc as soon as that committee meets. Here's the medical records. They have them in hand. But it's our staff that are doing that because really, honestly, it has to occur through the transfer center.
No, what I'm trying to figure out is, at what point have we said they've tried to transfer, there was no facility, and then what do we do then? What's next?
Well, I think
it in the bill?
as I understand it, would say we just keep on going.
Well, that's what I'm asking. Where's the end?
When God calls our loved one home, I would imagine. And as I mentioned, that's why I told the story of the gentleman who resided in our institution, whose wife became very well known to the entire institution for a year and 9 months.
Okay, thank you.
Members, any other questions?
A lot of dilemmas. You might just say a little bit about family disputes over who has the actual say over what happens to the patient and how that intervenes in decision-making in the hospital at that time.
Well, I've seen everything under the sun, and I've lived through some of these personally with the loss of my own mom just 4 years ago. It's an understatement to say that these are trying times that we all face, and they're times of grief. Miss Allman was correct when she said, and every single one of us will face this, either for ourselves and or for a loved one. It's inevitable. Death is the one thing that has 100% penetrance in the population. There are beautiful unified families. Mrs. Smith was just a stalwart, loving advocate for her husband. But there's also situations where we have split families. The very first one I was involved in, the gentleman's daughter worked at our institution. The decision maker was the patient's wife, his second wife, so not the mother of the daughter. To this day, she sees me and thanks me for actually proceeding with the process, because she realized this was the only way that dad is going to be able to be released, because her contention was my dad would not want this. And he was full life support, dialysis, breathing machine, and had been devastated by a viral infection.
I think we've all learned a little bit about care. If you're not enough ECMO machines, there weren't enough ventilators around the world. So is that rationing of care? No, we just didn't have enough ventilators for the circumstance that occurred. We got ventilators. Many people died because they went on a ventilator as opposed to not going on a ventilator. I mean, these are all decisions that you wonder if the decisions are the right decisions based on the ethical decision-making. I mean, so I'm only saying all these things because we debated this bill on the floor of the House for 5 hours. Let me say that again, 5 hours. I stood at that front mic for 5 hours. So I'm only saying that to say that this was a very difficult circumstance, and there was a lot of crying going on the floor of the House. And I wish that we could come with that compromise that's been discussed, where we can put those things in there that make the bill the law a better law than what it is. But I do get a little upset sometimes when somebody comes up, and it doesn't happen today, presents what is actually a malpractice case as if it was a case where a mistake was being hidden through the use of an ethics committee. So anyway, I appreciate y'all letting me pop off a little bit. I've been here 30 years. 30 years. I was here 8 years when I passed this bill. It was talked about as death panels on the federal level, death panels. So, we will get to where we need to get, I think. These are tough circumstances, and I'm not satisfied at all with the answer that we have.
Well, that's our fundamental hope and prayer too, and these things take time, as evidenced by even just the conversation tonight. So hopefully coming together and hammering this out one more time.
Yeah, they do take time. I wish I could stay here forever and fix it.
30 more years. You ride when you were 10? How's that work?
Any other questions, members? Thank you.
Thank you. Appreciate you all.